everybody. Welcome and thank you for participating in CTAC's Patient Input Consultation webinar for RF TAF, which is Gilead's new fixed-dose combination medication to treat HIV infection. My name is Jack Moore. I'm one of the policy researchers here at CTAC. Before we begin, I'd just like to ask anyone who's not already done so to please mute their line by pressing *6 on their phone. That'll help us avoid any interference during the webinar. Also, if we could quickly test the raise hand feature. So that's just this symbol right here with the person raising their hand. If you could just click on that for me, it should show me in the participant section that you've done that. You can use that feature if you have any questions at the end of the webinar. All right, great. It looks like that feature is working. And so if you could just click on that again to remove it, perfect. Okay. So before we begin, I wanted to take a moment to talk about the Canadian Treatment Action Council, or CTAC. For those of you who are not already familiar with our work, CTAC is Canada's national civil society organization that addresses access to treatment, care, and support for people living with HIV and viral hepatitis co-infection. At CTAC, we meaningfully engage with a broad number of stakeholders ranging from people living with HIV and hepatitis C, frontline service providers, healthcare professionals, and policymakers. We work in collaboration to identify, develop, and implement policy and program solutions. All right. So our agenda for today, we're going to start by reviewing the common drug review process and provide an overview of market access to treatments in Canada. We're going to follow that by giving you an introduction to RF TAF and talking about some of the key characteristics of that medication. Then I'm going to go into some key findings from clinical trials about RF TAF. And at the end, I'll explain how you can have your voice heard as a person living with HIV or a caregiver of someone living with HIV. And then everyone will also have the opportunity to engage in discussion and ask any questions that may arise. So we usually begin our webinars by providing an overview of market access and the common drug review process. And more recently, we've created a video that captures how drugs get to market in about 5 minutes. I'll play this short video for you now, but if you'd like to view it again, it's available on our website and also through our CTAC YouTube page.
Canada has a unique healthcare system, and sometimes it can be complicated to navigate. Canada's healthcare system is made up of 13 separate provincial and territorial programs and 6 additional federal plans, making healthcare in Canada a shared responsibility between the federal, provincial, and territorial governments. A drug can take as long as a decade to develop, and our regulatory review bodies might take as many as 5 more years to conduct thorough reviews. So what's going on during that time? And how do medical treatments get from clinical trials to a public insurance plan? Once a pharmaceutical manufacturer has created a new treatment or molecule, they must take it through clinical trials before bringing it to market in Canada. These trials evaluate whether a drug works and whether it's safe.
Sorry everyone, just a little technical difficulty with the audio there. I'm just going to start the video from the beginning.
Canada has a unique healthcare system, and sometimes it can be complicated to navigate. Canada's healthcare system is made up of 13 separate provincial and territorial programs and 6 additional federal plans, making healthcare in Canada a shared responsibility between the federal, provincial, and territorial governments. A drug can take as long as a decade to develop, and our regulatory review bodies might take as many as 5 more years to conduct thorough reviews. So what's going on during that time? And how do medical treatments get from clinical trials to a public insurance plan? Once a pharmaceutical manufacturer has created a new treatment or molecule, they must take it through clinical trials before bringing it to market in Canada. These trials evaluate whether a drug works and whether it's safe. A drug can take years to develop and study, with clinical trials often involving hundreds of people testing the drug. Manufacturers will create many molecules, but only those that prove effective during clinical trial are developed further. Some molecules are developed and never advance to become a treatment. It is important to consider that treatment development costs a lot of money, and manufacturers will generally seek to recoup those costs. When the manufacturer is confident that they have a competitive, effective treatment, they will submit the drug, along with clinical trial data, to Health Canada for review. Health Canada reviews the drug to determine if it provides clinical benefit and if it is safe. Once Health Canada concludes that a drug is safe and likely to provide clinical benefit, it is approved for sale on the market and can appear on private insurance plans. However, if a drug is to be listed in most of Canada's public formularies, the process is long from over. These are the public drug plans that many Canadians depend on in order to access essential medications. After Health Canada approval, the drug in question is reviewed by another body, the Canadian Agency for Drugs and Technology in Health, or CADTH. This agency is funded by the federal and provincial governments, except Quebec, which has an independent process. CADTH oversees a process called the Common Drug Review, or CDR, which conducts a review called Health Technology Assessment, or HTA. Many countries conduct HTAs, and there are different ways to measure health technologies. An HTA is conducted not just on medications and drugs, but also on any health technology, like a new pacemaker design, for example. Ultimately, the Common Drug Review seeks to answer the question, is this treatment cost-effective, and will it provide improved clinical benefits to Canadians? The Common Drug Review will assess the drug for listing on public insurance plans and must conclude whether it can provide equal or improved clinical benefit compared to its cost, and whether that makes it more cost-effective than similar treatments. How much money should be spent to achieve how much clinical benefit? Once the CDR concludes its assessment, it sends a recommendation to all health plans, federal, provincial, and territorial, as to whether or not the provinces should cover the cost of this medication and list it on their plan. The CDR will suggest that the provinces either A. list the treatment, B. list the treatment with clinical criteria and/or conditions, C. not list the treatment at the submitted price, or D. not list the treatment at all. Most treatments do not get an unconditional listing suggestion, and the majority are either not recommended for listing or recommended with conditions. In fact, in many of their reviews, the CDR has rejected or suggested not to list at a manufacturer's submitted price. Listing recommendations from the CDR are not binding or final. Provinces and territories receive the recommendation and are free to review the drug against their own standards or make their own conclusion from the Health Canada and CDR reviews. This allows provinces to realize local priorities and more closely manage provincial healthcare needs based on their budgets and populations. Each province does this independently, as each is the public payer of their respective province or territory. While many provinces and territories conduct their own reviews, some smaller provinces tend to follow the CDR recommendation and list or not list accordingly. As new drugs are developed and new needs are realized, provinces and territories must be vigilant to maintain a public listing that addresses contemporary local realities and responsibilities. Often, older treatments must be considered against newer treatments to see which contributes the most value for the most reasonable cost. This system is designed to review and respond to new treatments as they are developed, while allowing room for both price evaluation and regional healthcare priorities. Conducting HTA reviews at several levels with room for conditions allows provinces and territories more control over their public plans and healthcare mandates, while still allowing Health Canada and the CDR to review every treatment at the federal level. Timely and reasonable access to effective and safe medicines is a healthcare priority for Canadians, and while the processes described here account for cost, safety, and efficacy, some critics worry that they are redundant, duplicative, and very costly. Additionally, some critics note that the multiple points of review have resulted in some drugs being available on some public plans, but not others. Therefore, not all Canadians have access to the same treatment options. Is there a better way to realize our healthcare priorities at a reasonable price without rushing our review of safety and efficacy?
All right, so I'm just going to go back over the information that was covered in the video. Just to summarize the drug approval process, the first step is regulatory approval at Health Canada. That's where Health Canada reviews new drug submission data to determine a drug's safety and efficacy. Sorry, I'm just going to mute my line on the computer so there's no feedback. At this stage, if results are deemed favorable and the drug treats the condition that is intended to treat, a drug is then issued a notice of compliance, which manufacturers approval for the sale of the drug in Canada. In the second step of the drug approval process, all provinces, with the exception of Quebec, who uses its own assessment system, participate in the Common Drug Review. The Canadian Drug Expert Committee, or CTAC, reviews the clinical cost-effectiveness evidence for a drug. The Common Drug Review also looks at patient evidence. They collect patient input and want to know what people who are living with the condition and caregivers think of the drug under consideration. And because most people access HIV medications through publicly available drug programs, this step is particularly important in determining the accessibility of medications in Canada. The third step is to provide all jurisdictions with formulary listing recommendations. So either to list the medication, to list it with criteria or conditions, or to not list at all. Our video mentions a fourth option, do not list at current price, which was recently removed from the CDR's formal list of recommendation criteria. CTAC continues to give feedback on pricing elsewhere in the CDR. It's also important to mention that while the CDR provides a recommendation on whether or not the drug should be listed, it's jurisdictions themselves who determine whether they will list the drug on their formularies and under what criteria based on their own priorities, economic considerations, etc. So the purpose of this webinar is to ensure that the voices of people living with HIV and their caregivers are present in this process. By participating in this webinar and completing the survey, you're helping to inform the patient input submission that CTAC will provide to the Common Drug Review in order to inform their consideration of this drug for listing on public insurance plans. So now that we've covered the regulatory process, let's talk a little bit more in depth about RF TAF. RF TAF is a new once-daily fixed-dose combination therapy for HIV. RF TAF has been approved for sale in other countries, but has currently not yet received a notice of compliance from Health Canada. Now, RF TAF, like many HIV medications, is a combination of multiple drugs, and it's meant to be taken as a treatment for HIV. So the first component in RF TAF is rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor, also known as an NNRTI or a non-nuke. These medications work by inhibiting viral reverse transcriptase, which is an enzyme that's crucial for HIV to replicate itself. The second component is emtricitabine, which is a nucleoside reverse transcriptase inhibitor, an NRTI. NRTIs mimic viral genetic material, inserting themselves into the viral replication process and preventing viral RNA from converting to DNA. The third drug is another NRTI called tenofovir alafenamide, also known as TAF. TAF is a new prodrug of tenofovir, and a prodrug is a medicine that's inactive until it's taken. They then convert into their active form once they're processed in the body. So when TAF is absorbed by cells, it's converted into tenofovir. You might, throughout the presentation, also see the abbreviation RPV FTC TAF. This is just another way of abbreviating these medications, but for the sake of brevity, I'm going to be using RF TAF throughout my presentation. So the various components that make up RF TAF are already used in a variety of other medications that have been approved by Health Canada to be used by people living with HIV. 2 out of the 3 components of RF TAF are present in the single-tablet regimen Complera, which was approved for sale in Canada in 2011. The major difference between Complera and RF TAF is that they use different prodrugs of tenofovir. Complera and many other medications use an older version of tenofovir known as tenofovir disoproxil fumarate, or TDF. TDF was first approved for sale in Canada in 2002. Now, TDF is highly effective in viral suppression, and for that reason, it is one of the most commonly used HIV treatments. For treatment-naive people living with HIV, so those who have not previously used any HIV medication, TDF is a component in 4 out of the 5 regimens recommended by the U.S. Department of Health and Human Services, including Strivold and in Truvada as a backbone for Tivicay, Prozista, and Icentris. It's also a component of 2 commonly used alternative regimens, Atripla and Complera. Now, there are some concerns about potential renal and bone toxicities with TDF, and I'm going to be talking about that a bit more on the next slide. Potential impact on kidney health and bone health is very serious within the context of comorbidities experienced by people living with HIV. We see that people living with HIV are more likely to develop comorbidities such as kidney, liver, and cardiovascular disease than the general population. And this is due to several factors, including co-infection with hepatitis C and antiretroviral treatments themselves. We're also concerned about comorbidities as we see more and more people living with HIV aging. People with HIV are living longer than ever before. In fact, more than 35% of people living with HIV are aged 50 years or older. Research has shown that people living with HIV who are between the ages of 41 and 60 and who are already living with one comorbidity are more susceptible to inflammation and non-infectious comorbidities, including bone fractures and renal failure, and at earlier ages than the general population. So if we look at people living with HIV between the ages of 41 and 50, they're 16 times more likely to develop renal failure and 46 times more likely to develop renal failure when over 60 years of age. If we look at bone fractures, PHAs between the ages of 40 and 60, they're 12 to 16 times more at risk than those uninfected with HIV. So, considering that people are living with HIV longer than ever before and also taking medications longer than ever before, we're concerned about the impact that taking those medications might have on their long-term health. So TAF, tenofovir alafenamide, was developed as a way of addressing, as a new means of delivering tenofovir with the goals of maintaining the high level of viral suppression that we see in TDF while reducing the impact on bone and renal health. Both TDF and TAF are prodrugs of tenofovir, which, as I mentioned earlier, means they're converted into active forms of tenofovir in the body. The difference between the two is in the mechanism in which they're delivered. So TDF, the older version of tenofovir, enters the blood plasma and is converted to tenofovir in the blood, and then tenofovir is taken up into the cells. This requires higher dosages of TDF to ensure that tenofovir reaches the cells in effective levels. Now, tenofovir alafenamide, or TAF, is converted to tenofovir in cells rather than in the blood. Because this conversion process happens within the cells that it's targeting, it does not require as much medication. Plasma levels of tenofovir are much lower with TAF. In fact, 91% lower when taking 25 milligrams daily of TAF compared to 300 milligrams daily of TDF. So this chart is just showing the biomechanics of what I was just talking about. The darker blue line shows how the prodrug TDF is metabolized into tenofovir, while the lighter blue line shows how the prodrug TAF is metabolized into tenofovir. By virtue of its longer plasma half-life, TAF will contribute 90% less plasma tenofovir to renal cells than TDF. This means more tenofovir to attack HIV and less of it impacting renal cells. TDF would enter the plasma and be converted to tenofovir in the blood, as we see in the diagram. TAF is concentrated at the cellular level and converted to tenofovir directly in the cells. Because it's not concentrated in blood as TDF is, findings suggest TAF won't affect the kidney or bones the way TDF does, and might even be more potent against HIV, despite ultimately being a lower dose of tenofovir. Now, RF TAF, the medication that we're talking about today, sorry, is just one in a line of new regimens that Gilead has introduced to replace TDF with TAF. As I mentioned earlier, RF TAF is similar to Complera, with both including rilpivirine, emtricitabine, and a form of tenofovir. Gilead has previously come out with medications to replace their older TDF medications, releasing Genvoya, which was an update on Strivold, and Descovy, an update on Truvada. The development of these other TAF-based combination drugs means that there's an already existing body of clinical trial data on TAF and its effectiveness relative to other HIV regimens that we can look at on the next slide. Oh, sorry. So the chart that I'm showing here shows a list of various trials that have been shown that have shown that the elements of RF TAF are effective. So the table on the left-hand side of your screen shows trials where FTAF components were proven to be effective in combination with elvidigravir and cobicistat. The combination of EC-FTAF is marketed under the brand name Genvoya. The table on the right-hand side of the screen shows trials where rilpivirine, the R in RF-TAF, was shown to be effective. These were mostly in combination with FTDF, the combination of which makes up Complera. One important thing to note here, and you can see it in the center column in both, the far left column in both tables, is that these trials were done with a variety of different people living with HIV, including those who had been taking HIV medications and achieved viral suppression, with adults and adolescents who had never before taken HIV treatment, and with people who are experiencing renal impairment. So a broad group of people living with HIV who might potentially take this medication. The following slide covers the results of a study showing that RF-TAF is bioequivalent to the medications from the previous studies. Bioequivalence means that two medications have been proven to function roughly the same in terms of their availability within the body and how long they take effect. So bioequivalence here is shown through the peak amounts of drugs in the blood and the rate at which the drug goes down over time. And that chart at on the bottom in gray shows that RF-TAF delivers the medication to the body in a way that is bioequivalent to rilpivirine and the FTAF levels in EC-FTAF. We've seen some new clinical trial findings coming out that specifically looked at RF-TAF, and this is going to be the focus of most of the rest of the presentation today. So I'll spend a lot of time looking at trials 1216 and 1160. Both of these trials compared using RF-TAF to different regimens containing FTDF. While these trials are ongoing, preliminary results at 48 weeks from the trials was released in October of this year. I'll also briefly talk about trials 1624 and 1689, which looked at people using RF-TAF and other TAF-based regimens at the same time as LDF-SOF, or lipidovir sivosbuvir, which is marketed under the name Harvoni and is used to treat hepatitis C. Often we don't have great clinical trial data that looks at people living with HIV and hepatitis C, a co-infection, so this is really useful information for us. But let's first look at those two studies looking at virologically suppressed adults taking RF-TAF. So the designs of trials 1216 and 1160 are very similar. Both were double-blind, randomized clinical trials with participants who were previously using specific FTDF-based regimens for at least the prior 6 months. In each study, half of the participants were given RF-TAF in place of their previous regimen, while the remaining participants maintained the older regimen. Trial 1216 compared people using RF-TAF with those using RF-TDF, which is Complera, And trial 1160 compared people using RF TAF with those using EF TDF, which is a triplet. The primary endpoint or hypothesis that they wanted to prove in this research was that RF TAF was efficacious in suppressing HIV-1 infection measured at 48 weeks. And so those preliminary results I was talking about were at that 48-week point. So let's first look at viral suppression with RF TAF. This chart is from study 1216. And here we're comparing RF TAF with RF TDF. And you can see from the charts that the outcomes in terms of viral suppression were roughly equivalent, and that efficacy held up across age, sex, and geographic location. There were also no emergent resistance mutations to RF TAF found in this trial. So next, let's look at, all right, so here we're looking at study 1160, very similar diagram to the previous one, and again, this is, we're looking at RF TAF compared to EF TDF. Some minor changes, but overall efficacy was roughly the same in terms of viral suppression. So really what this is saying is that if you were to take RF TAF, it would be roughly equivalent in its effectiveness at reducing HIV infection to those other medications. For the next few slides, we're going to be looking at some of the different kidney and bone measurements that are used to see what impact medication might be having on kidney and bone health. So this slide combines the two studies. So study 1216 is on the left, study 1160 is on the right. And in both charts, RF TAF is represented by the light blue color. So the charts we're looking at here show changes in the filtration rate of the kidneys. And an increase on these charts means that blood is passing through the kidneys at better rates than it was before. And then as the numbers go down, we're showing a decrease in the blood passing through the kidneys. So in study 1216, where both regimens contain rilpivirine and emtricitabine with one of the two formulations of tenofovir, we see that the RF TAF regimen did slightly better than the RF TDF regimen in terms of filtration through the kidneys. In study 1160, you'll notice there was a slight decrease in filtration rate for the RF TAF regimen compared to EF TDF. A decrease in filtration rate in the first few weeks after starting a regimen containing rilpivirine is common, and in fact, the decrease that you see on that chart on the right is less than we might otherwise expect when starting rilpivirine. Often a reduction of as much as 10 milliliters per minute in filtration rate is common, and you can also see that the decrease in kidney function is slowly going away over time. So these charts are looking at the protein levels in the urine. It's another common measurement of kidney function because excessively high levels of urine protein can be a sign of poor kidney function. Both studies showed statistically significant reductions in urine protein among participants taking RF TAF. Patients were also screened for a condition called tubulopathy, which is a condition where the tubules that filter material in the kidneys become damaged. There were no reported cases of tubulopathy in either of these trials. Next, we're going to be looking at bone density. In both studies, participants taking RF TAF had about a 1% increase in bone mineral density in their hips compared to the other medications. Now, the trial investigators were interested in showing clinically significant changes in bone mineral density, and they put 3% as their marker for clinically significant changes. So if you look at the smaller table below, you can see that participants who had either a clinically significant increase or decrease in bone mineral density. And participants in both trials who were on RF TAF were at least twice as likely to have a clinically significant increase in bone mineral density in the hips. It's also important to note that participants on a TDF-based regimen were at least twice as likely to have a clinically significant decrease in bone mineral density. So we're saying bone mineral density improvements that are clinically significant in people taking RF TAF and clinically significant decreases in people taking the TDF regimen. This next slide is looking at bone mineral density in the spine. Here there was roughly a 1.5% increase in bone mineral density among participants on RF TAF in both studies. Similar to the previous slide, participants taking RF TAF are much more likely to have a clinically significant gain in bone mineral density in the spine, while participants in the TDF arms of the studies are much more likely to have clinically significant decreases in bone mineral density in the spine. Now we're going to be looking at cholesterol changes that were noted in these studies. So these charts show from left to right changes in total cholesterol levels, LDL cholesterol levels, which is the, quote, bad cholesterol, and then HDL cholesterol levels, known as the good cholesterol. In study 1216, participants using RF TAF had statistically significant increases in both total cholesterol and LDL cholesterol levels, as well as a slight decrease in HDL cholesterol. From a clinical health perspective, these changes did not create a major impact in total cholesterol to HDL cholesterol levels, and that's shown in the bar graph on the far right. A lower total cholesterol to HDL level is better because it means you have a greater proportion of good cholesterol in your body, but participants taking RF TAF maintained what is considered a moderate total cholesterol to HDL level. In study 1160, there were smaller but still statistically significant reductions in all cholesterol levels for participants using RF TAF. As in study 1216, changes in total cholesterol to HDL levels remained roughly the same as they had before the trial, and participants, on average, had what is considered a moderate total cholesterol to HDL level. So this is the last we're going to be looking at studies 1216 and 1160. And we're going to move over to looking at studies 1624 and 1689. And I wanted to briefly talk about these studies because it was an important investigation of co-administering RF TAF along with ledipasvir and sabosvir to treat hepatitis C. And ledipasvir and sabosvir are sold under the brand name Harvoni. They're one of several direct-acting antiviral medications that have emerged in the past several years to treat people living with hepatitis C genotype 1. There's existing clinical data that shows that LDV-SOF, when used in combination with TDF, can cause increased levels of tenofovir, which risks renal impairment and reduction. It also can reduce the amount of ledipasvir in the body. So the graph above shows data from a variety of trials that looked at LDV-SOF when it was co-administered with various regimens containing either TDF or TAF. The chart shows the amount of tenofovir on average that participants cleared through their kidneys, and lower numbers reflect less tenofovir clearance through the kidneys, and thus better clinical outcomes for people on these regimens. So on the far right of the chart, you'll see results for two different TAF-based regimens, ECF TAF, which is represented by the purple marker on the chart, and RF TAF, which is in light blue. Both of these regimens showed significantly reduced levels of tenofovir in the kidneys when administered with LDV-SOF when compared to TDF-based regimens. These results show that LDV-SOF can be safely administered with RF TAF and ECF TAF without any dosing adjustments to medications. So in summary, TAF offers a new delivery of tenofovir, which is designed to increase concentration of tenofovir in the target cells rather than in blood plasma. The new formulation was intended to address kidney and bone impacts of TDF-based regimens. In clinical trials of RF TAF, participants using RF TAF had better indicators of kidney function than those taking TDF-based regimens. Participants taking RF TAF also showed better overall bone mineral density in the hips and spine, a greater likelihood of clinically significant bone mineral density increase, and less likelihood of clinically significant decreases. One clinical trial showed slight increases in total cholesterol levels and LDL cholesterol levels among people taking RF TAF. However, changes to overall cholesterol ratio were minor, and participants on average maintained a healthy ratio of total cholesterol to good cholesterol. At the same time, it's highly efficacious with potent antiviral activity similar to other HIV medications. And in addition, clinical trials have also shown that RF TAF can be safely used alongside LDV-SOF to treat hepatitis C co-infection. So that brings us to the end of my presentation, and now it's your turn to give your input on RF TAF. CTAC has developed a user-friendly web-based survey for participants to fill out based on some of the questions that are included in the Common Drug Review. And a link to that survey is at the bottom of this slide, so the surveymonkey.com/r/RFTAF. So CTAC is asking a number of questions of folks to help with the patient submission, and those include the impact of living with HIV or providing care services for a person living with HIV, the impact of current HIV medications on your health from what you've observed or experienced, what adverse events have you experienced, and what do you consider tolerable and which ones are not, what's the impact of HIV treatment on caregivers and service providers? What are your experience with the components of RF TAF, so if you've taken any of the medications that are part of this regimen? And lastly, for those who have taken RF TAF, how does it compare to currently available treatment? That brings us to the end of the webinar. I'd like to thank each and every one of you for participating. It's fundamental that the voices of people living with HIV are included in the Common Drug Review patient input submission, so please don't forget to fill out our questionnaire, as well as provide the link to others that you think might be interested in the process. So thank you for listening, and if anyone has questions, you could enter those through the chat function. I'll also take questions on the phone line, and you can unmute your line by hitting #6. So I just got a question through the chat function from Brian, and it's, is TAF available in Ontario and covered by OHIP? So TAF is available in other formulations in Ontario. RF TAF is still going through the approval process with Health Canada. So there are folks taking it as part of clinical trials, but it's not currently available as other HIV medications are. And if you're interested to see whether RF TAF is available in Ontario, you can visit our website and go to the treatment access map, and it covers all of the medications that are currently covered under the Ontario Drug Benefit Plan. Off the top of my head, I'm not sure which TAF regimens are currently covered and which ones aren't, but all of that information is available on our treatment access map. No problem. Are there any other questions? All right. It looks like there aren't any other questions right now. My email is listed there. That's jack@ctac.ca. So if you'd like to send me any questions, please do. And I encourage you to complete the survey that we have on SurveyMonkey. You can click right through on the presentation here. And if you know anyone else who might be interested, feel free to share this webinar with them. It will be available